Hello everyone, we'll go ahead and get started with today's presentation. I'm Keith Freeman with the South Central Telehealth Resource Center, and we'd like to welcome you to our quarterly thought conference presented by the South Central Telehealth Resource Center. Today's presentation is also this month's feature presentation in the National Telehealth Webinar Series, monthly event sponsored by a partnership of the 15 Telehealth Resource Centers, providing timely information and demonstrations to support and guide the development of your telehealth program, presented on the third Thursday of each month. Located throughout the country, the 15 Telehealth Resource Centers serve as focal points for advancing effective use of telehealth and supporting access to telehealth services in rural and underserved communities. If you haven't connected with your regional TRC, please go to the website www.telehealthresourcecenters.org and find your local TRC for free resources and guidance in all things related to telehealth. We're also fortunate to have 3 national TRCs providing expertise on specific telehealth-related topics such as telehealth technology and telehealth policy. Today's presentation, If I Knew Then What I Know Now, Lessons Learned from Building a Telehealth Network from the Ground Up, is presented by Brian Colthorpe. Mr. Colthorpe is the Director of Innovation for Health Resources of Arkansas. He was hired as a case manager in 2001. He is a formal special agent, a member of Mensa, Rotary International, and Safe Passages. His undergraduate degree is theology, and he has a master's degree in psychology. He is also quick to point out that he has no formal IT training whatsoever. So with that, please welcome Brian Colthorpe.
Well, good afternoon, and thank you all for joining me this afternoon. Our presentation this afternoon is Lessons Learned from Building a Telehealth Network from the Ground Up. Health Resources of Arkansas hired me as a case manager back in 2001, and shortly after getting on board with them, they looked at my rather unique background and decided I would be better serving the agency if they put me into a role that was more of a troubleshooter. One of my first titles that I had with the company was New Program Support and Development Coordinator, which basically just allowed me to jump on board with any new program, any new policies, anything new that came down the road, whether it was iPads, cell phones, video conferencing, anything that they weren't really sure how to implement. They'd give it to me first, let me work out all the kinks, and then turn it over to one of the supervisors to manage from that point on. I think they quickly realized that I got bored rather quickly. So after implementing the equipment, getting everything up on board, getting the policies in place, and making sure everything was running fine, I could easily pass it over to managers who were more equipped and more adept at supervising the day-to-day activities of whatever program it was. Now, Health Resources of Arkansas is in 22 counties. We're a nonprofit community mental health center in Arkansas. We have clinics or facilities in almost a third of the counties of Arkansas. We were established back in 1969. We have about 320 employees, and we serve approximately 8,000 clients. Now, for those of you that don't know the difference between a DSL line and a T1 line, this is a great opportunity for you to go refill your coffee cup or update your Facebook page. Give me about a minute and a half, and I'm going to explain to you how our network works right now, and then I'll get back into the rest of the presentation. Right now, we currently have a 22-point hub and spokes MPLS brand network. We have 19 T1 lines that are 1.5 megabytes each. We have one 4.5, which is really 3 bonded T1s at our Searcy clinic. That's because we have 2 video conferencing units there that run almost nonstop. Our phone lines, our computers, and our PRI, public relay interface, all run through that particular facility on the south end of our agency, so we have to have a rather large circuit there. We also have a 125 meg fiber optic circuit at our host, and that's split down the middle, so we have some DIS on that and some PNT. We have one business DSL in a rented office that we have down in our Augusta clinic, and I want to make the reference right now that if you have a business class DSL line, that will run a Tandberg or Polycom telemedicine unit. You can do video conferencing with a business class DSL if you're not doing much of anything else with it. And since that's a one-man office down there, as long as he's not on the phone or the computer at the same time, that DSL line seems to handle video conferencing. We also have 12 Polycom HDX and VSX 7000 video conferencing units and 14 Tandberg units. We have a video border proxy, which is probably the most important piece of equipment that, in my mind, that we have in our telemedicine arsenal, and I'll get to that later. And we have a scheduling bridge. Ours is a Polycom RMX 1000, but you can easily have a Tandberg or any other brand name scheduling bridge out there. We have 5 terminal servers with a published RDP, and we have 2 PRIs. The one in Searcy on our south end, as I mentioned, and then our larger one at our host at the Batesville area, in our Batesville area. And those allow us to turn our telephones into a networked phone system and basically turn ourselves into our own phone company. Another very valuable piece of equipment when you're talking about a large network like this. Now here's where we're located. If you look at the counties there in the center, those 10 counties in the center, those were very important to us about 6 years ago. We at that time we were not in 22 counties. We were in the 10 central counties only. We had 10 clinics and we had 3 day treatment facilities. We had to provide medical services, psychiatric, pharmacological, prescription services in all of those counties. Now, as you can imagine, Conway there, the big green dot on the left with 60,000 people in population, Little Rock 200,000, and Jonesboro over on the right with 60,000 people. It was fairly easy for us to get doctors from those municipalities and bring them out to the little blue dots, Cleburne County, Clinton, Heber Springs, Jackson County, Newport. It's very easy for us to get doctors to drive an hour, 45 minutes, half an hour from their large facilities in Conway, Little Rock, and Jonesboro to our closest clinics. However, the red dots up in the north central portion of the state, you see Stone County, Izard County, the 4 red smaller dots up in the top, we had a lot of difficulty getting doctors to travel all the way up there, some of them as much as 2 hours on the road to get to those facilities. What we ended up doing for the years before I got here was we had those doctors travel 2 hours on the clock, get to that facility after being in the car for 2 hours, see clients for 4 hours, and turn around and drive 2 hours back home. And that was pretty much the only way we could get a psychopharm physician or a psychiatrist to get that far north into these rural counties. Now the only options we had at that point were to travel. We didn't have video conferencing back then. We really didn't have any partnerships with any other agencies up in that area, and there weren't. To be honest, there was a it was a large difficulty getting psychiatrists or doctors in this portion of the state. So that's how we handled it. Not the best way of doing it, certainly not the most cost-effective, but it worked. Now, back in about 2005, we ran into a dilemma, quite a conundrum. We had 3 physicians that were handling those 4 northern counties that were traveling those hour and a half and 2 hours a day to and from. They all basically gave notice at about the same time. One of them was going to return to New York and start practice there. Another one had a blossoming private practice, and he was going to quit working with us and go and devote time to his private practice. And one of the other physicians was going to move over to a regional medical center. And so that was going to leave our 3 traveling physicians that took care of those northern counties. That was going to leave us hanging. And so they called me in and wanted to know what were our options. What could we do, since it was almost near impossible for us to hire somebody else to travel all that time? How could we do this? And so my answer after a short recess was to say video conferencing. Now, it was a hard sell in the front end, I'll tell you that. First of all, the price of the video conferencing equipment, to purchase them outright or to lease them, did not encourage anybody in our senior staff to just run right out and branch out into this new world. The second problem was we needed to get a physician down in one of our larger facilities. You can see the large red dot down in the bottom, just about in the center of your screen. That's our Searcy clinic, and We didn't have any problems getting physicians to that facility. We needed to find a physician who was willing to champion this cause and willing to branch out and do video conferencing, which was something that, you know, bordered on the unethical. If you asked many clinicians and physicians at that time, they weren't sure it was a good idea. If you couldn't reach out and touch the client or the patient, not really sure that that's the way to do business. So we had to first of all, find a physician willing to do the video conferencing for us. And then secondly, we had to be able to find a way to make this cost effective, at least break even. And I was told that several times. If we can't at least break even with it, I'm not sure it's doable. So here's what we ended up with, and this is the cost analysis. First of all, I wanted to show how far the travel was for each one of these physicians. If the physician had to go to Mountain View 2 days a week, he was spending an hour and a half on the road getting to the site and an hour and a half home. Melbourne, about the same with Batesville, and Ash Flat was a solid 2-hour drive there, 2 hours back. So when we did the cost analysis, I brought that map up and I showed it like this. If we're going to do this project, we're going to purchase or lease 5 video conferencing units, 1 for each of the 4 remote areas, and then 1 for the doctor who's going to be sitting there doing all of the work in Searcy. Now, to lease those 4 video conferencing units, it was going to cost us $600 a month on a 6-year lease. To get the T1 lines, we were looking at around $550 to $650 per month for the T1 lines in each one of those rural areas. Now, again, this did not include any type of subsidizing by the federal government, no grants involved. This was just me throwing something out there without any assistance beyond the scope of what I had in the Batesville area. So we were looking at $2,700, $2,800 of T1 lines, internet lines. So our total was going to be about $3,350 a month out of pocket to get this thing up and running. That didn't sound good. And my CEO at the time, the COO, they were not impressed with this number. So then I went to the second portion of the screen and tried to explain to them how things are working right now. We have physicians that travel to Melbourne 4 times a month, and they travel about an hour and a half or 2 hours a month. They put in about 16 hours in the car, windshield time, 16 hours a month. When they go to Mountain View, it's another 16 hours. When they drive 8 times up to Ash Flat, 2 hours there, 2 hours back, that's 32 hours of windshield time. Another 32 hours for Batesville. So you're paying, our company at that time was paying a physician, a psychiatrist, 96 hours of salary to listen to his radio and stay on the road. I'm going to lowball this like I did back then and say $50 an hour. I think we can all agree that that's probably not the case. The numbers are quite a bit higher than that. But I lowballed it for them since I didn't have access to physicians' salaries then. I still don't have access to it now. I'm going to guess $50 an hour. So there was $4,800 a month that we were paying the physician to be behind the wheel of his car. Now look at the lost revenue. For each one of those hours, let's assume that the physician was going to do $50 worth of revenue-based services. Now you're looking at $4,800 that we didn't get, that we could have got if he was seeing clients a full 8 hours a day. Now we're looking at $9,600 a month that we're losing, $3,300 a month that it's going to cost us to go to telemedicine. Suddenly, it was making more sense. So having sold the idea, we went ahead and moved forward and decided to purchase, lease the 5 units, get with the IT staff, get with the our telecom installers, and make this thing happen. Next came the next big hurdle that happens with any new project. The idea that knowledge is power. And I've grown to believe this one axiom over the years, and that is that you should never, ever pay for free information. I believe you should pay for experience. I believe you should pay for wisdom. Consulting, all of that's wonderful. There are things that you should pay for that are wrapped around this knowledge and information world. But information that is already available free, whether it's on the internet or through the ATA or through a program like you're listening to right now, if that information is free and you're taking good notes, there's no need for you to have to pay for that again. And so as you can see from this cartoon, I keep this with me as often as I can because in the technology world, this is what costs you. It doesn't cost you to have somebody come in and install your video conferencing unit as much as it costs you to not take good notes and figure out what to do when they won't connect the first time, and the second time, and the third time. Each time that a video conferencing unit doesn't connect like it's supposed to in one of our agencies, we lose revenue, we lose face with the patient because the patient is looking at us going, dude, you can't get a TV working? The psychiatrist loses faith in the system and is less and less, less and less eager to branch out into a new world, a new venture. So we lose on all levels, and it's because we didn't know enough about the equipment that we've installed to keep it running. And so one of the things I want to mention here at this point, before I get into the how-to guides, and you can look at the references there. It's just a short list of the free information that's available on the internet. One of the things I want to make mention here is that when you get ready to step out into the world of telehealth, when you want to venture out into video conferencing, you want to be very careful not to relegate this to your IT staff. The IT staff have a place in this, and it's a very strong role in developing your telehealth network. But you should not relegate it to them, pass it on, and say, let us know when it's ready. And here's the reason why. If any of you have ever given a project to your IT department, given them no real guidance and just said, we need to have this running. We want laptops. We want netbooks, and we want them to be able to connect to the internet, and we want them to be able to call back into our central electronic health records from any location in the state, and we want the staff to be able to do their electronic medical records, progress notes, physician's notes from any home, anywhere that they can get cell signal. You give that project to your IT staff, and what you will get in return are iPads, netbooks, cell phones, and tablets that are the most secure, the most highly encrypted, the fastest, and the most state-of-the-art solitaire game that you have ever seen in your life. Because if you cannot get your staff to buy into the project, if you cannot get your clinicians to believe that this is a worthwhile project, if you cannot get your physicians to be willing to step out by faith and do something that none of the other physicians in the area are doing, all you're going to get out of all of this equipment is a solitaire game. That's it. And when we first started, this is one of the lessons that I learned. When we first started with this project, our telemedicine units, for the most part, sat idle in a lot of our clinics because we had a difficulty convincing the staff that this process was not only ethical, but legal and reimbursable and good for the client or good for the patient. Here's some of the resources that are out there. Don't ever pay for free information. Again, the program that you're listening to right now, go to the website as soon as you get done here. Go to the website, look at the resources that are available in your community. Follow up on this. Don't pay for free information. If you hire a consultant and all he's doing is giving you information you can already get on the internet, that warm fuzzy feeling isn't worth the price tag that you're paying the consultant. You want to pay a consultant for wisdom and experience, not just the knowledge that he's going to bring to the table, because knowledge is available on just about any website. Here's some of the equipment that we used in the beginning. Routers. Now, and I want to say, let me refer back to this again with the cartoon. Okay. The only difference between the guy on the couch and the guy with the TV repair sticker on the back of his shirt is that he knew how to do it one time. Once you've had your television set unplugged by accident and you know to go behind there and plug it in to get the screen to come up, nobody ever has to tell you again how to do that. It's easy. It's like riding a bike. It's simple. But if they use a really large technical name for it, instead of saying you need to turn your TV off and back on, how many times have you heard your IT staff say you need to power cycle your equipment? Well, if you told me I needed to power cycle my equipment and I've never done it before, I'm not going to know that there's a green button on the front of the screen and you just push it once and it comes on. But if you walk me through for the first time how to power cycle my equipment, which just means turn it off and turn it back on, you'll never, ever have to tell me how to do that again. And for most people working in the business field today, that's the same with telemedicine. Here's the 3 things that you need. You need a router. Once you work with your telecom coordinator, whether it's AT&T, Ritter, CenturyLink, whatever the telephone service, internet service provider that you have, whatever their role is, when you get to setting up your network, you will go to them and you'll say, I need this facility to connect to this facility, and I need internet service between the two. They will show up with something that looks like the Cisco router. And all that is it turns the internet service that comes through the wall into something you can use on your computer or your video conferencing unit. The bottom piece is a Cisco switch. Now, these are items you can purchase yourself. The Cisco switch at the bottom requires no programming in most cases. For those of you that can remember the old modular telephone systems, the old POTS lines, you have one phone in your house and you want 3 or 4 phones in your house in the same jack, you'd plug a little jack in there that had 3 or 4 holes in it, and you'd plug 3 or 4 phones into it. This Cisco switch is the high-tech computerized version of that. It takes Cat5 lines that you plug into port number 1 and lets you plug 24 other devices into it and split it off of the same line. All it is a high-tech splitter. Requires very little configuring. Most of the time, no configuration at all. You plug it in, you plug the ports in, and away you go. Once you've done this one time, you don't have to pay for somebody else to show you how to do it. It's very simple. Now, the item in the middle there is a video border proxy. That becomes very important if you're going to want to connect with people outside of your little community. Now, here, as you remember seeing the 22-port MPLS network that we have, HRA has 22 sites that all connect together. They all talk to each other on what you might consider a virtual private network. Nobody else can talk to us. We just talk to ourselves. But if we ever want to take a video conferencing unit and be able to dial into somebody outside of our little 22 sites, that's when the video border proxy comes in. The video border proxy, what it does is it sits on the edge of your network and manages the security incoming and outgoing. It's a gatekeeper. And what you do is you take the video conferencing units that you have on your side in the private network and you register them with this border proxy. Then people in the outside world, say in another state, when they want to talk to you, they dial up your address, and the only information, the only data that can be passed through your network goes directly to that video conferencing unit and directly out. They can't find out what your host IP address is. They can't chase down your username and password. They can't exploit you with malware. All they can do is connect to that video conferencing unit. It becomes very, very helpful when you're talking about the security of a local network. Here's some video conferencing equipment. The one on the right you see is what's been passed out to us recently by UAMS. These are the Tandberg type equipment. All comes in one great big nifty rack, and if you go to an authorized vendor of Tandberg, Polycom, whoever your particular resource is, they can stack that all up for you, put it all together, have it configured and installed for you, and all you need to know from that point on is how to make it work when it doesn't work. We have some of the older versions. The IAV that's there in the top center, that's the old Polycom SDX 7000s. When we bought our first 5 units 7 years ago, that's what we got. They did not look pretty, but it did the job. We set them on top of 35-inch large screen TVs, and there's a reason for that too, and I'll get to that here in a minute. There's more equipment that you can buy if you need to as you expand your network. The Polycom bridge or a Tandberg bridge down in the bottom center. That's helpful for scheduling. If you get to the point where you have so many video conferencing units going that you're not able to easily tell which one's on and which one's off, and you need to make schedules down the road, that scheduling unit works really well. It also ties in and lets you make multi-point conferences. So you're able to connect all 22 of your conferences to one and let one guy talk and 22 people listen. That was something else that tied in very well with our cost analysis. Imagine an agency of 350 people who are in 22 different counties, and they all need to come to an insurance seminar once a year to update their insurance cards. The easiest way to do that is to let that insurance man stand at the host at the main conference room at Batesville, and talk into the video conferencing unit and let the other 21 sites see him over video conferencing and do everything else remotely. Sign the forms, fill out the documents, and mail them in. The other thing we have is an IPVCR. It's basically TiVo for video conferencing units and the video conferencing bridge. Our company doesn't have one, but as we move forward into health information exchanges and we start connecting our services with larger hospitals and larger facilities, regional hospitals and training units, you're going to want to be able to do what's called store and forward. You're going to want to be able to have a clinician sit down with a client or a patient, do a 1-hour session asking all the appropriate questions, and allow a physician on his own time later on down the road to be able to review that session and give an analysis, give an assessment of it. Instead of the way things work right now, which is we get a client in one location, we realize he's in crisis, we realize that he needs something more than what the clinician's able to provide at that moment, so we get on the horn and we start calling up psychiatrists and physicians hoping that one of them will have a free moment to get online and see us now. What the IPVCR allows us to do is record that session, put it out there in the cloud somewhere where the physician or psychiatrist, when he has a lunch break or when he's at his last 15 minutes of the day, he can pull that up on his time without blocking special time out of his schedule and be able to pull it up, review it, and then make an assessment and pass that information back on. Some of the larger facilities are already doing that. It's not new technology. We haven't got to that point yet, but that's our next step. Here's some of the things that we did right. I'm going to get to a long list of things we did wrong, but here's some of the things that we did do right when we started developing our telehealth network. First thing we did is we collaborated with our telecom installers, and we collaborated with our telephone sales reps and our IT staff. The reason for this is the video conferencing units work best on a T1 or larger circuit. But most of what you do with video conferencing isn't going to require an entire T1 line. And most of the time we don't even use up half of the bandwidth. So that other half of the bandwidth, if you collaborate with your telecom installers, you collaborate with your telephone sales reps, you can use that other half of bandwidth for network telephone services. Or you can use that other half of bandwidth for internet service provider connections, whether your EHR or your EMR is in the cloud or whether it's at a host location in some server farm somewhere. You can use what's left of what's not needed out of those T1 lines to connect to other agencies, to connect back to your host, to be able to run your email services, things like that. We did that on the front end. We didn't know that that was such a great idea until it all came together and we went, wow, we really did that right. But we didn't know we were doing it right at the time. It just seemed to make sense. Research the rules and regulations for reimbursement, whether it be Medicaid, Medicare, private insurance, the VA, whatever it is. If you're going to expect to get paid for video conferencing, for distance telehealth, make sure that the people who are paying you are okay with it. Make sure not only that they're okay with it, but that you can follow all of the rules that they present. Early on, one of our payer sources, we tried, when we first got set up with telehealth, we researched the rules and regs, and we realized that one of these payer sources would pay for telehealth services, for clinical services, crisis services, screenings, psychiatric services. So we immediately, once the network was up, we began providing those services and billing. The reimbursement didn't come through right away. What we found was this particular reimbursement source had that on their records, but had never actually had anybody do it before. So they had to work out the kinks on their end, how exactly to make those codes work and to get paid and to allow us to get paid for those codes. So we had 2 or 3 months of hit and miss training, trying to figure out between us and the reimbursement or the payer source until we actually started getting checks from them for those services. So don't expect everything to work right away. Start out slowly. We started out with 5 video conferencing units, then we moved to 10, we got another 7, and now we're up around 30. But start out slowly. Another huge, if you don't take anything else away from today's presentation, start with your medical staff. And the reason is you're going to, every agency has a hierarchy. And if you're in a medical facility, it probably starts with your psychiatrist and goes down to your medical folks and then drops down to your nurses and then your LPNs and your CNAs. If you're in a therapeutic setting, you probably have your PhDs, and then it goes down to your LPCs and your LACs, LMSWs, and on down the road to your case managers and such like. Start at the top. If you cannot get your medical staff or your psychiatrist to buy off on this process, there's no way in the world you're going to get your clinicians or case managers to buy off on it as well. We pretty much force-fed this to the medical staff because we had no other options. Now, looking at hindsight, that was a good idea. In fact, if I was to do it again, it's what I would do. We would have a drop-dead date and say from this point on, these services are going to be provided from a distance through telehealth. We're not going to phase it in. We're not going to give you a chance to see if you like it. We know the process works. This is what we're going to do. That's not a palatable suggestion to the medical staff or to the clinical staff, but it really is the only way to get the ball rolling. You're going to have to find somebody who's okay with it and make it happen. Find a champion and champion the cause. Learn how to configure the equipment before and during the installation process. If you don't know how to work the equipment beyond dialing somebody up and going to the directory and finding somebody on your phone book list, if nobody in your agency knows how to do that, knows how to do anything beyond that, the first time it doesn't connect like it's supposed to, the first time you dial and nobody answers on the other end, you've lost resources, you've lost services, you've lost face, you've lost faith, and you've lost a whole lot of time because you're going to have to pay to have somebody else come over and fix it for you, and then they're going to leave, and they're going to wait until you call them again and again and again. Have somebody on staff who sits there and watches for the first time, watches them configure and install and set up the equipment so you have a working knowledge of how to troubleshoot the equipment, because trouble will come. Just like you have staff members who call in sick on a full day of clinical services, you're going to have a telemed unit that's set up for a full day of services, and day one or during the first session, you're going to have a fuzzy screen, or you're going to have snow, or you're going to have visual but no audio, and you're going to have to fix that, or it's going to reap dividends all the way through the day. You have to have a way of fixing it. You have to have troubleshooting. Again, I mentioned the minimal transition time. You just need to force feed it beginning and then work from there. We expanded our reach beyond our own agency. This is where that video border proxy came in handy. It was very important for us to reach out beyond our little circle. We realized that the emergency rooms in the state of Arkansas, the emergency rooms in our catchment area, they have what's called a stroke unit, which is video conferencing for stroke victims. Now, as you can imagine, they don't have stroke victims there 24 hours a day. What they do have there more often than strokes is people in crisis who may or may not need to be assessed and screened for the state hospital or for inpatient settings. In the past, what we would do is put somebody in the car and they would drive to the nearest emergency room and they would do a face-to-face screening. What we have possible now is for our therapist to roll her chair around to a video conferencing unit in the same facility that she's working, do a screening through the emergency room's video conferencing unit, do the screening, make the assessment, fill out the paperwork, roll back around and continue seeing clients. This is possible now with video conferencing. It was only possible because we purchased a video border proxy, which allows us to reach outside of our own little world. Trainings in Little Rock. A therapist or a case manager is going to have to get in their car, drive 2.5 hours to Little Rock, spend an hour or two in training, 2.5 hours back to get their annual certification. This can be done over video conferencing, and they lose the 2 hours of training instead of the 8-hour day. We use large monitors for clinical interviews. This is very important for what we call the window view. If you can imagine the old days when your neighbor stepped up to your kitchen window while you had a hot apple pie out there cooling, and you were standing at the sink and they were standing in your yard and you talked to your neighbor through the open window, that is the general effect that we want when we do clinical services. Invest in large screens. The video conferencing equipment itself can be small, it can be compact, it can be portable. But what you want is a screen that's large enough that holds the life-size head and shoulders of the doctor on the other end, and the life-size or larger head and shoulders of the patient on this end. The reason for that is we have our patients, we come in and we have them sit down in front of this television, and if you get the size right on the television and you get the audio right, within about 10 or 15 seconds, the patient quits thinking that they are talking to somebody through a television and starts feeling like they are talking to somebody through a window. And that window effect is what we shoot for on our clinical services. If you can get that, it normalizes the session for the client. If you've got the volume up too high or you've got an echo, Lord of mercy, if you've got squiggly lines on the screen or you have jitter, if you have somebody that's already walked in here and they have psychiatric issues already, and then they see jitter on the screen, or the voice and the lips don't match up, you've already asked for a lot of trouble. Get large video conferencing screens, and all they are HD TVs. That's all they are. You can buy those at Walmart. They don't have to, or anywhere. I'm being careful not to plug anybody. You can get it at whatever store you could buy a large TV screen at. They don't have to be anything special. They don't have to have the word Polycom or Tandberg at the bottom of them to be a good TV screen. So get large monitors and go with that window effect. Continue to seek out new resources, new grant opportunities, new connections. The biggest thing that we did right is we believed in what was going on. We believed that this was a good idea, and we processed that and sent that out to the people who were working with this. If you believe it's going to work and you believe it's a good idea, that will transition into the clients, the patients, the doctors, the staff. They'll believe it as well. Here's some of the things that I wanted to add to this, and that is to make sure you prepare the sites appropriately. It's not a lot of money to make sure that you've got the right paint in the background, you've got the right lighting, so that when you're looking at a patient, you're not going to see a bunch of shadows, or the patient's looking at you, they're not seeing the bright light, the bright sunlight coming through the blinds behind you. Set up your offices correctly, and if you go online to the ATA websites or any of the resources that are listed, they will show you how to set up. They will give you advice on how a room should look. Furniture-wise, privacy, make sure it's HIPAA compliant, things like that, monitor size, color schemes, all of these things can be found out online. Make sure your staff are prepared, make sure that they know how to use the remote control, the cameras, make sure that they know all the things that can be used. A psychiatrist who's wanting to look at jumpy legs and sweat and red eyes, he can zoom in and out, he can look at blackheads on the nose of your patient, and the patient has no idea that they have got that close of a view of them. They can zoom down, they can pan around, they can see the expressions of the other people in the room, and this is very helpful in one respect because it gives a sense of anonymity for the psychiatrist. They can look and see what's going on in the room, whereas if they were in the room with them, their head tilt or their eyes flashing from one side to the other would give away what they're staring at to the patient, whereas the psychiatrist now has basically a 180 view of the entire room, can pan, zoom, and focus in on anything he wants, and the patient only knows that he's looking in general. Make sure you prepare the clients. Not every client is a good fit for video conferencing, so make sure you screen them ahead of time. You can screen them by diagnosis, you can screen them by how long they've been in the system, by how stable they are, by their functioning. Whatever screening process you want to use, you're looking for patients who are going to be okay with this. Again, prepare the patients. Give them prior notice. Allow them, explain to them the kitchen window effect. You can even use my apple pie analogy. Explain to them the kitchen window effect, and in no time they'll buy into it, and they will normalize their session quite quickly. Avoid the desire to go cheap. Again, the screens are a good example of that. We didn't use Skype. We didn't use webcams. The worst thing that you can do when you set up your telehealth network is set it up so that your psychiatrist can do screenings over an 8-inch laptop or a netbook. That in my opinion is not acceptable. I'm sure most of the clinical medical staff would agree that that's not an acceptable practice. Use your nurses. Most of our payer sources told us that all we needed to do was have a staff member in the room with the video conferencing unit and the patient. We've stepped that up, and we usually have a nurse, whether it be LPN, RN, APN, whatever the case is. We make sure that we have a nurse on the other end with the patient, and I think that's just good practice. We had options for uncomfortable clients. It's difficult for a client to drive 2.5 hours to see a physician, or to wait 2 months for a physician to drive up there once a quarter instead of every month or every week. But those options were available to the patients who weren't comfortable doing video conferencing. And so it makes it more difficult. It's not as convenient for the patient, but we want to make sure we had those options. We weren't force-feeding this to every patient and every individual that walked in the room. We distinguished the telemed billing from on-site billing, and your reimbursement sources, wherever they are. There are codes for local services, face-to-face, and there's codes for telemed services. You need to get that in play as early as possible. It cleans up a lot of the issues down the road for the billing folks. We had enhanced on-site services. We wanted to make sure that you understand that this enhanced our on-site services. It didn't just replace them. And again, that ties in with the options for uncomfortable clients as well. Now here's some of the things that we did wrong. First thing that we did wrong was we bought from a secondary vendor, only because I didn't know. I went to the vendor that we were dealing with and said, we need video conferencing units. I know nothing about it. Set us up. I didn't know the right questions to ask. I didn't know if there were grant opportunities available. I didn't know they had larger and smaller units. I knew nothing about it. I went to the local vendor and said, you guys know how to buy video conferencing units. Set us up. What I would suggest is going with an authorized vendor for Polycom or Tandberg or whatever the particular device is that you're looking for. With the authorized vendors, the installers will come out and they will give you a full view of all of the functionality of the equipment. They will set you up. If you go with, I think I've got that listed here. If you go with Polycom, they've got a grant assistance program. They'll help you figure out ways to get the money you need to buy this expensive equipment. If you go with Tandberg, they have the same thing. If you go with other agencies, they have the same thing. They will help you figure out ways to subsidize your equipment. We didn't know to do that. We didn't have that. We didn't ask the right questions. We got equipment that was appropriate, but it was by a fluke more than anything. We didn't ask the right questions. We didn't go with an authorized vendor. The vendor that we did have did excellent service and did a wonderful job for what we asked them to do. We just didn't ask all the right questions. So go with an authorized representative. We paid about twice as much for the video conferencing units we got. Really, we needed to have spent about half that on the video conferencing units and the rest on the big screen TVs. We didn't know that then. You all know that now. A telemed coordinator from another state said, this is something we did wrong. I have a list of people that I've asked advice from that gave me wrong advice. I've asked the wrong people and they gave me bad advice. I asked a telecoordinator from another state talking about our setup, and he said we would not be able to connect our units inside our local area network to the outside world like we're doing right now with UAMS. We would not be able to do that. We would have to either install public circuits that could talk to the public or install our private circuits that could talk to ourselves privately, but you can't cross over. You see, you can't do that securely. He said that's just the way it is. There's nothing you can do about it. And for 2 years, there wasn't anything we could do about it because I didn't ask anybody else. Come to find out, a little video border proxy for about $1,200, which is one of the cheaper items that we purchased for our video conferencing network, does the job wonderfully. We have a private network. We talk to everybody in the outside world. I asked the wrong person for advice. Video border proxy, it sits on the edge of the network. You can read through that. I don't have to continue. But we spent about $85,000, or excuse me, we spent about 30 man hours, $105 per hour with a tech support staff, with a contracted tech support staff, trying to figure out how to talk to the outside world by adjusting our firewalls and port settings to keep our network secure but still be able to connect to a public network. We were doing this, we were running these 30 hours of contracted service because one of the IT specialists had told us that a video border proxy will cost you $85,000. And so even if once I found out that there was such a thing as a video border proxy, I was then told that it's $85,000. You're never going to be able to afford it. So we went for quite a while not affording it. And so, but we needed a solution, so we got the IT staff out there, and they started tweaking the port settings on our network, trying to figure out a way to have a secure connection to, say, UAMS, but keep everybody else locked out. And so we spent a lot of money doing that, only to find out that, well, we don't need an $85,000 video border proxy, and yes, there are some out there that cost that much. The one we need only costs about $1,200. Wow, big difference. It took me about 36 hours to make the decision that we needed a border proxy for $1,200. Our ISP, our Internet Service Provider, said there weren't any programs available to help reduce the cost of Internet services. We were going to be stuck with that $600 a month per site for as long as we wanted video conferencing. By 2009, our monthly bill on 22 sites is $16,533 a month. USAC, if you ever look at your phone bill, at the bottom of the phone bill, you've got this little thing that says Universal Service Fund. Everybody that pays that $1.19 or $2.50 a month to the Universal Service Fund, that money actually goes someplace. It goes to a Universal Service Fund. And the Universal Service Administration Corporation called USAC manages that money, and one of their tasks is to give that money back to rural health agencies, whether they be community mental health agencies or rural hospitals, rural health units, to help subsidize their expensive rural Internet services. Now, I spent 2 years going through their red tape and paperwork trying to get the full service, the full reimbursement for the USAC funding. It's a nightmare, and it's not their fault. They are contracted under the FCC, and if you've ever dealt with the FCC, you know that they've got red tape that's wrapped up around their red tape. So I spent a couple of years doing that, and then came across an agency called Telequality Communications. Again, not plugging for them, just telling you who we used. Came across an agency called Telequality Communications. They're out of Texas. There are other agencies, I'm sure, nationwide that do the same thing. But these folks helped us walk through this huge red tape nightmare to ensure that we got the maximum allowable reimbursement from our USAC funding. And so now our $16,533 a month IT bill, or Internet service bill, is now floating around $7,000 a month. That was well worth that consulting fee. Again, you don't pay for free information, but you pay for experience and you pay for wisdom. They had experience on how to get through that red tape. I paid for that, and I think it was a valuable dime, if I could say it any other way. Grant coordinators. 2008, I had a grant coordinator say there wasn't any money available to set up networks or buy equipment. There's grant money out there to encourage interagency cooperation, planning, sustainability, but absolutely nothing to actually buy the equipment. As you can imagine, that wasn't the case either once you start looking into it. A billing representative told me in 2009 that Medicare and private insurance will not now and will never pay for telemed services. Well, they do. So as you can see, if you ask any of the wrong people the right questions, you'll get bad advice. Don't stop with one person. If you get an answer that doesn't sound right, go to the next person on the list. A lot of what I did was I heard what sounded like an expert answer from an expert, and I just moved on and tried something else. And eventually came back around through happenstance and found out they really didn't know what they were talking about. The experts do. Now you're asking yourself now, where are the experts? Well, you're tuned in to one of them right now, and I'm not talking about me, but this website. And ATA is another great expert. These folks have have free resources available, and they have the right answers, and they're verified. In 2009, we purchased 10 more units and put them in sites that had fractional T1 lines. Be careful with that. We had fractional T1 lines. 768 kilobytes is what a fractional T1 line is. In one of our sites, we had 2 telemed units running at the same time. They both ran at 384. Well, there went all of the fractional T1, and lo and behold, the phones and the computers were also on that T1 line. So when we had both video conferencing units going, our computers didn't run all that fast. And if you got a phone call, you were pretty lucky. So be careful with that. Go with at least full T1 lines. It's worth the money. You'll see that there's really not that much difference between a fractional and a full T1. It's worth the extra money to just go with the full T1. When the telemeds were on the computers, ran slow, I mentioned that. You don't have class of service precedence. On a dedicated business class DSL, again, you don't have class of service. You cannot dedicate and say, I want half of this site or half of this circuit to go to video and the other quarter to go to voice and another quarter to go to data. You've got to be able to dedicate that type of bandwidth out. Here's some of the resources that we used. Heritage Communication, they were our telecom coordinator, and they helped set us up with our network. I can tell you, this is a national broadcast right now. They only work in Arkansas. If you're in Florida or you're out in Seattle, they're not going to be able to help you. All I'm giving you is the information of who helped us. This is who we used. Find somebody like them. Coordinate. Telequality Communications, they helped us work through the fiasco of the USAC funding. There are other agencies I'm sure out there that can help you. Find somebody who specializes in that. It's well worth the money to do it. USAC, Universal Service Administration, these are the folks that can help you reduce your IT bill, your internet service provider bill. These are the resources available. If you have any questions, I know I kind of ended on a stutter there, but if you have any questions, I'd be more than happy to answer them. I'll do the best I can. Again, we do not have a vast network. We have 30 telemed units in 22 sites, actually in 15 sites, expanding to 22. We talk mostly to ourselves and expand out to other agencies periodically. If any of that sounds like something I can help you with, here I am.
Thank you. We have some questions online. If you could repeat it for the audience.
Certainly.
One of the questions is, do you think there's value in using a video as a service company where the healthcare provider doesn't have to build or maintain a large network infrastructure?
I'm not sure I could repeat that word for word, but the question was, do I know if there's value in video as a service agency, video as a service program for a health provider that what?
So basically, so the healthcare provider doesn't have to build their own network.
Oh, so the
outsourcing.
Right, very good. The short version of that is there value in outsourcing? Yes, and that is a resource that's available. Certainly, had we not built it from the ground up, we probably, if we started today, very good chance that with what we use video conferencing for, we would have outsourced. Yes.
And then another question.
Muted.
Okay, so that should pull. Okay, so another question is, it appears that you are mentioning and recommending purchasing equipment on your own. How do the FDA's MDDS requirements and the medical device requirements apply to this scenario?
Well, again,
Unmuted.
What I would suggest doing is contacting either Polycom or Tannenberg or whoever your product is, going with an authorized vendor, presenting that to them. They do this nationwide. Actually, they do it worldwide. They'll know the rules, they know the policies, and they will help you meet those standards, whether it be JCO, CARF, or whatever your certifying authority is.
Muted.
Okay. So another question would from the online audience: could you address the potential problems if using wireless and tablets remotely?
Unmuted.
Yes, I have seen I've seen tablets used. I know that Polycom and Tannenberg both have a mobile version available for dialing into video conferencing units. I don't recommend wireless, especially in the mental health field. The opportunity for jitter and the small screen sizes, both with tablet and with wireless. And I say wireless typically mainly because when I start thinking of wireless, I immediately think of mobile devices. I don't see the point in having a a large static teleconferencing unit connected to a wireless router. Doesn't seem to make sense. So when you're talking about mobile devices, I immediately start thinking small screens, small bandwidth. If you're talking about clinical services, anything that's going to require a screening or assessment, a clinical evaluation, it just sounds scary. Sounds like bad news. I would wait for the technology to catch up.
Muted.
Myself here. Another online question. Are there any other costs associated with your telemedicine card? Can you approximate maintenance costs, licensing fees?
Unmuted.
For us, we have two sets. One, we have our Tandberg units, which were provided from UAMS through a BTOP and E-Link grant, and so they would be probably more adept at explaining what their fees are since they manage those units. On our side, the Polycom units, once they're installed, we have the option for a service agreement. Risky or not, we opted out of a service agreement. We've not paid a dime for any of our teleconferencing units since we bought them 7 years ago and 5 years ago. We purchased them. They showed up. They worked. Of the 15 units that we have in place, I think over 7 years we've had 3 that have gone down. When they go down, we turn them in for maintenance. We pay the maintenance cost and bring them back online. What I've seen of Polycom and Tandberg units in our facilities, they're very resilient. They last 5 or 7 years. Unless you kick them off of the stand and let them drop on a concrete floor, you're not going to really need a service agreement. And that's just my personal experience. Other folks, larger agencies, may have a differing opinion.
Muted.
Okay. Another question from the audience is, obviously much time and effort goes into setting all of this up. What FTEs do you have dedicated to this startup, and for how long?
Well, the dedicated FTE wasn't even an F. It was me, and I had other projects and other jobs going on at the time. What we ended up doing to set up the network really took realistically about 8 hours of teleconferences with our service providers, explained to them exactly what we needed, and then I spent probably 6 or 7 days during the provisioning process because I wanted to go around with AT&T and Windstream and all of our telephone service providers to watch them install all of the routers on site. I didn't need to do that, but we did. And then all of the training and such, I would venture to say 15 hours of full-time employee service on our end. The rest of it is, like I said, you're relying very heavily on your authorized vendors, your service providers, to do the job you're paying them for.
Muted.
All right, okay, well, last question here. With as quickly as technology changes, how difficult is it to keep up with it when equipment gets outdated?
Well, that's a good question.
Unmuted.
Our oldest equipment right now, you saw, let me rewind to this real quick. There you go. I mean, that thing looks like the top center, that's what we bought 7 years ago. It looks like something from War of the Worlds, if you ask me. It works we have probably 4 of those left in service right now, and they work just as well today as they did back then. Whether it be Polycom or Tandberg, it's just like updating your firmware. If we send something in for maintenance, they will add new software to it, they update it, and we move on. But this unit that you're looking at here has had no firmware updates, no software updates since we bought it 7 years ago, and it works just fine on our network and connects to the video border proxy and to the outside world. These things have a long lifespan. If you like all the brand new bells and whistles, you can get them, but if you just need something that functions the way it is, the way you bought it, they'll last at least 7 years in my experience.
Okay, well, that conclude this quarterly thought symposium and this the presentation here for the National Telehealth Resource Center webinar series. We'd like to hear your feedback, so here's a link to a survey that you can go online and tell us what you thought of the presentation, and also provide us with some ideas on future presentations. So with that, we thank you very much. We will get a copy of the slides, hopefully, and we'll be sending out a link to those. So thank you very much.